Hi, everyone. Welcome. We are here today to have another Whitetulip Health Foundation program. My name is Semanur Yalvak. I work at the Rocky River Public Library as an adult services associate. Today, we will be having another health awareness program, which is sponsored by Whitetulip Health Foundation. And our topic is cancer screening can save your life. And Dr. Yilmaz will be our guest today. Dr. Elif Yilmaz is a Hematology and Oncology Fellow at Georgetown University, Lombardi Comprehensive Cancer Center in Washington, D.C. She will be starting her academic practice in a few months following her graduation. Welcome, Dr. Yilmaz, and floor is yours.
Thank you so much for the introduction. As you just mentioned, my talk will be about cancer screening and prevention, and it is sponsored by Whitetulip Health Foundation. I have no financial disclosures that are relevant to this talk. This talk is intended for public, not for medical professionals. I've used a lot of figures and schemas in this talk on my slides to make it easier for the audience's understanding. I've not made any of those figures. Those are available online. You can find them easily by just Googling them. So just a disclaimer here. What are my objectives for this talk? Is to discuss benefits and potential harms of cancer screening for some of the most commonly seen cancer types, to discuss the timing and methods of screening for different cancer types, and to increase public awareness in cancer screening and facilitate people's access to care. Some terminology to discuss before we get started. I assume that a lot of people who are joining in this talk know what cancer means. I'm pretty sure everyone has heard it or does know someone who has cancer. Cancer is an umbrella term for diseases in which abnormal cell growth without control, and as it progresses, it invades other parts of the body. Polyp, on the other hand, is a growth that protrudes from the inner lining of the body. For example, our nose has an inner lining, our mouth has an inner lining, and polyp means a growth in those locations. We're going to use this term when we come to colorectal cancer screening. And cancers, as a general information, cancers are usually staged through stage 1 to 4 based on the extent of sites of involvement. Stage 1 and 2 are usually considered localized cancers, and the cure rate are high, approaching to 80 to 100% for this earlier stage cancers. Stage 3 and 4, on the other hand, are considered advanced cancers, and the cure rate are not so great. The rate of curability decreases significantly as a cancer progresses from stage 1 to 4, and the stage 3 cancer, depending on the cancer subtype, could be cured in maybe 50% of the cases, maybe more. But stage 4 cancers are really hard to cure. I'm not going to say it's impossible. Certain stage 4 cancers can be cured, but it's really a low possibility. Why am I talking about this? It is important to understand the importance of screening. Curability means you get rid of the cancer for the rest of your life and it never comes back. When you cannot cure a cancer, more than likely it's going to cause a patient's death eventually. So I would like to get started with colorectal cancer screening. What is colorectal cancer? It is, so the colon is our large bowels. Rectum is the lower part of our large bowels. So colorectal cancer means any cancer that arises from our large bowels. So you can see the large bowels on this figure. It's the larger structures on the outside, and the small bowels are like curled up inside the large bowels. So there are about 150,000 new colorectal cancer diagnoses each year in the United States, and over 50,000 deaths are expected annually. The overall mortality of colorectal cancer has been in decline since 1990s, and this is in part due to the screening efforts. However, the incidence of colorectal cancer in the younger population, in patients who are less than age of 50, has increased since 1990s. The explanation is not quite clear for this. There are many different theories, and none of them are quite validated yet. But this really underlines the importance of cancer screening in colorectal cancer. So what is the natural course of colorectal cancer? So most colon cancers arise from small but precancerous polyps. As I mentioned in the beginning of the talk, polyps means a growth, simply a growth from the inner lining of the body. So if you look at this figures down below, this is the inner lining of your colon. This is your colon wall, the darker pink structure. The lighter pink is the inner lining of the colon, and the polyps are these small growths. As they start growing, certain cells in that polyp acquire certain mutations, which change the characteristics of those particular cells and cause them to grow and divide uncontrollably. As they grow and grow, they just take over, and then they invade through the wall of the colon and get stuck to other structures in the vicinity. And at that stage, it is called cancer. This whole process from a benign or not cancerous polyp to cancer formation takes about 10 to 15 years. This is important for screening because it gives us the interval to screen patients, especially with colonoscopy. So what are the goals of colorectal cancer screening? First of all, is the prevention of that from colon cancer. And this is mainly through for colonoscopy, which I will be discussing later in detail. It's the best method that we can use or we have for colorectal cancer screening. And when you undergo colonoscopy, if your doctor sees polyps in the inner lining of your colon, they just remove it and they go for a pathology. And even the pathology shows that there were evidence of cancer, small cancerous growth in those polyps. And that's the end of it. You're not going to have a colon cancer because of that polyp, because it's been cut out, it's been removed. So that's why the colon cancer screening halts progression of colon polyps to colon cancer. And another goal of colorectal cancer screening is that early detection of cancerous lesions before symptoms develop. So as in many other cancers, colon cancer too does not cause any symptoms until the cancer gets into a very advanced stage. As you can see on this figure on the right side, 7 out of 10 people who are diagnosed with colon cancer will not have any symptoms of colon cancer prior to the diagnosis. They are either diagnosed as a result of colon cancer screening, or they are diagnosed incidentally. Let's say they had an abdominal imaging, belly imaging for another reason, and it showed a suspicious finding. And this early detection is very important because it can change the outcomes and goals of treatment from getting rid of cancer forever, which we mean curative intent, to a palliative intent, which is basically alleviating the symptoms and making sure that we can extend the patient's life as much as possible before they die from colon cancer. So what is the timing of colorectal cancer screening? There are different medical societies with slightly different recommendations. So I'll mention the major ones here. The main authority in this cancer screening subject is United States Preventive Services Task Force, because the insurance insurances look into USPSTF, which is the United States Preventive Services Task Force recommendations in deciding whether they're gonna cover the costs associated with cancer screening or not. So the recommendation from USPSTF and American Cancer Society has two levels, actually. There is grade A recommendation and there is grade B recommendation. Grade A recommendation means it has the strongest evidence to back up the screening. And this is to start cancer screening at the age of 50. Grade B recommendation is that it doesn't have a so strong of a data as in the case of grade A recommendation, but benefits of starting to screen at that age still outweighs the harms associated with screening. So the grade B recommendation is to start screening at the age of 45. American College of Gastroenterology also recommends screening at the age of 45. What you should understand from this slide is, as a summary, you should start discussing colorectal cancer screening with your physician, with your primary care physician or gastroenterologist at the age of 45. You might not start screening at the age of 45. Your insurance might not cover it until the age of 50, but 45 is the age that you should start cancer screening with your physician. And the screening is continued through the age of 75 or until the life expectancy is less than 10 years. So the second, let me just clarify the second part a little bit. So you might be at the age of 80, but you don't have much other diseases, you have a relatively healthy life and good quality of your life, and you are expected to live through your 90s. So you can still qualify for colon cancer screening at the age of 80. 75 is not a hard stop. And the frequency of cancer screening, colon cancer screening, depends on the type of the method that is used, which I will get to it later. So let me go back to the previous slide. These recommendations are for average risk individuals. There are some people who have more than average risk for the development of colon cancer in their lifetime. And let's talk about these people a little bit. So if you have one or more first-degree relative with a history of colon cancer or an advanced polyp, then you should start colon cancer screening at the age of 40, and this has to be with colonoscopy, not with the other methods, and you should get a screening colonoscopy every 5 years. And if you have a family history of high-risk colorectal cancer syndrome, such as Lynch syndrome or family adenomatosis polyposis, then you should start screening at a younger age too. And it depends on the magnitude of the risk. So what is a Lynch syndrome? It is important to mention here, I put this figure here to be able to go over it, because many people will have a family history that might suggest or raise the possibility of Lynch syndrome, but they would not know about it. So Lynch syndrome is an inherited condition. You inherit certain genetic mutations from your parents, and that increases your likelihood of having certain types of cancers. The most common types of cancers associated with Lynch syndrome are colorectal cancer, stomach cancer, pancreas cancer, urinary tract cancer such as bladder cancer, prostate cancer for men, and ovary or uterine cancer for women. So if you have any personal history of these or a family history of these cancers, then bring this up with your physician and discuss, and make them notice that you have this family history, because you might benefit from genetic testing, and your insurance will likely cover this. Another high-risk population is having a personal history of inflammatory bowel disease, such as ulcerative colitis or Crohn's disease. You will see the ads of medications often on TV that are used in these diseases. And depending on the risk factors or the intensity of your disease, you have to start cancer screening at a much earlier age, at least and the first 8 years have passed since your initial diagnosis. Another high-risk group is prior history of abdominal radiation. You might be a survivor of childhood cancers, and you might have received an abdominal radiation when you were a kid, or you might be a survivor of lymphoma and you've received radiation as part of your treatment regimen. So in this case, you have to start colon cancer screening 5 years after the radiation therapy, or age over 30 years, whichever is later. What are the colon cancer screening modalities? I put a figure on the right side again to explain it a little bit easier. So the gold standard, which means the best test we have available for colon cancer screening, is colonoscopy. It might not be a pleasant experience for a lot of people, but it is really the best method for detection. So how it is done is that a day before your colonoscopy, you start with a light diet, and around 6 p.m. in the evening, again, the day before your colonoscopy, you start bowel prep. It includes basically drinking a liquid at large amounts and to cleanse your bowels. So you basically, as you drink that fluid, you're going to go to the bathroom very often to have a bowel movement, again, which will clean inside your bowels. If you don't do this properly, then the quality of the exam is going to be very poor, and it will have to be repeated. So on the day of colonoscopy, you go to an outpatient center, like a surgical center, or like in a hospital or clinic, and then they will give you a light sedation. They will put you asleep, and then they will put a camera on the back, and they will check inside your bowels to see if there are any polyps or lesions like cancer. FIT testing and FOBT are stool-based tests. So how it is done is that they just send you a kit, and you put a stool sample somewhere on the kit, and then you send it back to the lab, and lab tests your stool to see if there's any blood or not. You have to do these tests annually. And on the other hand, colonoscopy is done every 10 years if it is normal. FIT DNA, or you might have heard of it, which is Cologuard, is another stool-based test. In that setting, again, they will send you a kit, you will provide the stool sample, mail the kit back, and they will look for cancer DNA in your stool. Flexible sigmoidoscopy is sort of a baby colonoscopy. The idea is similar. They just look into the lower part of your large bowel, as depicted here, like on the figure, the dark red part is the part where they would put the camera, not the rest of it. And CT colonography is a type of imaging study, a CAT scan or CT scan, that is dedicated to detect polyps or cancerous lesions in your colon. Again, we have many different alternatives for colon cancer screening. We say the colonoscopy is the best method, but in fact, the best screening test is the one that you can complete per instructions. Because if you don't complete the colonoscopy per instructions, it just becomes a poor test, and it doesn't worth the effort. So this is a really, I think I got this figure from the website of Mass General Hospital, and it really summarizes well in terms of different screening methods and how they're covered and how often they need to be done. When we started colonoscopy, I already explained it to you. If it is screening colonoscopy, insurance, including Medicaid and Medicare, has to cover it because it's a government recommendation to start screening at least at the age of 50. So you don't pay out of pocket for this. And if the findings are normal, then you just repeat it every 10 years. If you have polyps removed, it depends on the type of the polyp. You might need to repeat it every 5 years, every 3 years, or if you had a large polyp removed, then you might need to repeat it a year later. What are the potential harms of colonoscopy? It is really rare. It's way less than 1%. So way less than 1 in 100 people who have colonoscopy will have a side effect or a complication associated with it. The complications could be bleeding a little bit, like a day after you had the procedure, rarely infection, and rarely bowel wall injury, which means that creating a little hole in your bowels, and that could be a serious condition. Flexible sigmoidoscopy is, again, the idea is similar to colonoscopy. It is, again, putting a camera on your behind, but bowel prep is not required in this case. And oftentimes for screening purposes is covered with the FOBT or FIT testing, which is like the looking for blood in your stool. It's done every 5 years if normal. And the coverage might depend on the type of insurance. Virtual colonoscopy, again, this fancy CT scan that is dedicated to take a closer look in your large bowel. And it is expensive, so not all insurances will cover this. You have to check the coverage with your physician. And if you get a virtual colonoscopy, and if it is normal, then you just get it every 5 years. I don't see that very commonly used. It might be an insurance issue, I'm not sure. Or it might be that there are not that many centers that are specialized to do this test because it requires expertise. FIT testing and Cologuard, again, or stool-based methods. FIT looks for blood, Cologuard looks for cancer DNA. FIT is done every year. It's cheap, covered by insurance. Cologuard is done every 3 years. It's a bit expensive, might not be covered with your insurance. I think the insurance coverage has been extended in the last few years, so just check with your physician. So that was the end of the colorectal cancer screening. Now we're going to be starting with breast cancer screening. So breast cancer is one of the most common cancer types. It's way more common in women, as you can imagine, compared to men, but men can also develop a breast cancer. 1 in 8 women in the United States will develop breast cancer sometime in their life. And 8 out of 9 women who are diagnosed with breast cancer will have no family history. So don't say that you don't have a family history, you don't need screening. Every woman will eventually need screening after a certain age, because family history is not the only risk factor. And if the breast cancer is detected early, it's quite curable in majority of the cases. So there are about 260,000 new cases of breast cancer each year in the United States, and there are about 40,000 deaths. The breast cancer mortality or deaths from breast cancer have decreased significantly in the last few decades, and this is the end result of breast cancer screening efforts. And screening is important because it makes patients eligible for curative treatment options, as in the case of colorectal cancer screening. So what are the risk factors for breast cancer? Age over 50, obesity, especially in women who already been through menopause, having a dense breast tissue, menopausal hormonal therapy, though this depends on the type of hormone therapy used, whether it's estrogen only or combined estrogen and progesterone, and the number of years that the treatment was used. Early age at first period, which is defined as less than 13 years of age, or late menopause. Nulliparity is not carrying any pregnancy to full term, so not having any babies or children. Personal or family history of breast cancer. Another risk factor, which is a significant one, is certain genetic mutations such as BRCA1 that you might have heard of, BRCA2, or Lynch syndrome that I discussed in this section of colorectal cancer screening. Smoking and alcohol use, and history of chest radiation. This might be a potential problem in survivors of lymphoma. What is the timing of breast cancer screening? I think it's best to divide this into different age periods. For women who are younger than 40, it is not recommended because the incidence or the frequency of the breast cancer diagnosis is not that common under the age of 40, so the potential harms associated with screening does not outweigh the benefits. Between the age 40 to 49, though, there has to be a discussion started about when to start breast cancer screening. it should depend on the patient's risk factors and their preferences. There could be a false positive on the screening method, which is the mammogram in most cases, that it can show some abnormalities that in fact does not stem from breast cancer, and it might lead to unnecessary biopsies. But still, again, every woman has a different risk. There are certain risk calculation tools to help you understand your breast cancer risk that you can do with your physician. The American Cancer Society recommends starting screening at over the age of 45, not at 40. Again, it's all numbers games. When we look at the period between the age 50 to 75, then every medical society agrees that you have to get started with breast cancer screening if you have not already. It is done with mammogram, and it is done every 1 to 2 years, depending on the risk factors and the frequency of screening. The recommendations differ from different societies. American Cancer Society, for example, recommends annual screening until the age of 55, which is sort of the peak period to diagnose women with breast cancer, and then reducing the screening frequency to every 2 years. So it depends. Again, this is going to be another discussion between you and your physician. For women who are older than 75, you can stop it or you can continue it, again, if the life expectancy is more than 10 years. And at this point, if you had done annual screening up until this point, you can start extending the interval to every 2 years. So this is a nice figure to explain the breast cancer recommendations, not just for mammogram, but other screening modalities based on the recommendations from different medical societies. I will focus on the last two columns because that's pretty much what matters me the most. The third column, ACS, means American Cancer Societies, and the fourth column, that means United States Preventive Services Task Force. So for mammogram, ACS, American Cancer Society recommends annual mammograms starting, actually this is not so true, it's not 40, it's 45 now. These recommendations are changing very often. USPSTF, though, recommends a discussion starting at the age of 40. Some women can be screening, can start screening between the age of 40 to 49, but you have to, there's like a hard start at the age of 50. You have to start breast cancer screening at the age of 50. And USPSTF recommends screening every 2 years. Clinical breast exam is useful in women who have breast complaints, and ACS recommends that it is done every 3 years until the age of 40, and then annually for women who are older than 40. USPSTF says there is insufficient evidence for clinical breast exam, so they're not sure if they should recommend it or not. But when you have a regular gynecology appointment, oftentimes the gynecologist will do a breast exam in addition to a vaginal exam. So you will get this done anyways if you're going to a gynecologist at least once a year. In terms of the MRI considerations, USPSTF says that there is insufficient evidence for the use of MRI. MRI is an expensive test. So USPSTF always considers the costs associated with screening before making their recommendations. On the other hand, ACS recommends that mammogram is a good tool for women who have high risk, more than 20% lifetime risk of breast cancer. And that's often what we recommend as oncologists, that in women who have really high risk for breast cancer, we recommend screening with both mammogram and MRI in an alternating way. So if you're getting a mammogram this year, then we recommend that you get an MRI next year. Then mammogram and MRI is alternating once a year. And a self-breast exam is not really recommended by any of the societies because it could be quite misleading. When you do a self-exam, and if you find something like a area of nodularity and your physician doesn't appreciate this on the exam, you will still have the anxiety of having breast cancer, and you will ask for additional tests, which your physician will prescribe to ease your anxiety. And those additional tests can show some findings that are not arising from breast cancer, and this can lead to unnecessary breast biopsies and really an overwhelming degree of anxiety surrounding it. So breast self-exams are not recommended. So I just put this here just to show women who've never had mammograms to see how it is done. So mammogram is basically a special type of X-ray. So they put your breast between two planes and they basically take pictures of it. They take horizontal pictures and oblique pictures, and the results are shown on the right or depicted on the right. The normal mammogram looks like the one on the left upper side. The benign cyst looks like an area of increased density, but not that bright. Cancer looks like really bright density, and oftentimes it will have spicules arising from that. And calcium deposits, which are often indicate benign disease, will be seen as like small dots. So what's the role of breast exam and ultrasound? I've already alluded to this. Clinical breast exam could be done, oftentimes is done by the gynecologist, but it is never a substitute for mammogram. You cannot say that, oh, I've had my clinical breast exam this year, I don't need mammogram. No, that's not true, because it's never as good as a mammogram. And ultrasound is not recommended. Some people might find mammograms a bit painful because they really like sort of mash your breasts between those like radiation planes. But ultrasound is really not a good test because it can lead to a lot of false positives. And it is only done if your screening mammogram is abnormal. It is used as an assistive tool. That's basically the end of the breast cancer screening. By the way, I just realized that I forgot to say in the beginning, if you have any questions, you can type on the Q&A box and I will get to them at the end of the talk. So lung cancer screening, let's start with some lung cancer facts. There are about 234,000 new cases every year in the United States, and unfortunately, it's the leading cause of cancer-related deaths in adults in the United States. There are over 150,000 deaths every year from lung cancer. And the mortality rate, if you have noticed, is much higher in lung cancer compared to breast cancer, for example, or colorectal cancer. This comes from the fact that lung cancer is often diagnosed in advanced stages, and it's really hard to cure advanced stage lung cancer. About 80% of the lung cancers related to smoking or environmental smoking exposure. Early stage lung cancer, stage 1 and 2 lung cancer, could be curable in majority of the cases with surgery or radiation plus minus chemotherapy. But early stage disease is rarely symptomatic. That's why people often get diagnosed at late stages. So what are the goals of lung cancer screening? It's basically similar to colon cancer and breast cancer. It's the early detection and to make patients eligible for curative treatment options, and also prevention of death from lung cancer by, again, offering curative treatment options. It's been also shown that studies have been shown that lung cancer screening improves smoking cessation rates. I guess this comes from the fact that when a smoker starts lung cancer screening, they understand that the gravity of the situation, that yeah, they can get cancer from this habit of smoking, and that's why they have to go get a CT scan done every year until they stop smoking for a certain period. So what are the criteria to meet to be qualified for lung cancer screening? So USPSTF, again, United States Preventive Services Task Force recommends that people who are between the ages of 50 to 80 who have to any pack-year smoking history who are current smokers or have quit within the last 15 years. These individuals do qualify for lung cancer screening. How do we calculate pack-year smoking? So as it is shown on this figure, if you smoked 1 pack a day for, let's say, 30 years, then you multiply the amount of packs that you smoke per day with the number of years smoked. So it's basically 30 pack you're smoking. If you smoke 2 packs a day for, let's say, 15 years, again, it's 30 pack you're smoking. And the lung cancer screening is continued every year annually until the 15 years have passed from smoking cessation. So how do we screen for lung cancer? It is with low-dose CT scan. Low-dose CT is a type of CT scan or CAT scan. So it uses radiation, but it has much less radiation compared to a conventional CT scan. It gives 90% less radiation. So that's why it can be done safely every year until the person stops smoking for 15 years. And it's much better. It's as good as conventional CT scan in terms of finding out about lung nodules or lung cancers, and it's much better than chest x-ray. Chest x-ray also is a low dose radiation, but it's not good enough to detect these lesions. And it's very quick, as in the case of a conventional CT scan. You just go in, get your picture snapped, and then you just get out. It takes about like 5-10 minutes. So that's basically the end of the lung cancer screening. Now we're going to be discussing the prostate cancer screening, which is more of a debatable topic. So what are the prostate cancer facts? It's the second most commonly diagnosed cancer in men. 1 in 8 men in the United States will be diagnosed with prostate cancer sometime during their lifetime. And the autopsy findings actually show a much higher incidence. When investigators did autopsies on men who have died from other causes other than prostate cancer, they found out that up to 30% of the men in their 50s and up to 70% of the men in their 70s had evidence of prostate cancer. So this striking contrast comes from the fact that prostate cancer often goes unnoticed because it doesn't cause any problems. And it's, in majority of the cases, it's a slowly progressing cancer. So it can stay quiescent for many, many, many years before it becomes symptomatic, gets into the bones and cause problems. Some prostate cancer patients, for this reason, will never need any treatment. Some men, though, have certain factors that indicate high risk for development of prostate cancer. These are age over 50, because as they age, the incidence of prostate cancer increases. African-American race, family history of prostate cancer, especially having a prostate cancer diagnosed in first-degree relatives prior to the age of 65, and certain genetic alteration. Again, Lynch syndrome comes into play in prostate cancer too. BRCA1, BRCA2 mutations do matter for prostate cancer as well. What are the pros and cons of prostate cancer screening? So screening has a small benefit in preventing death from prostate cancer. If you screen 1,000 men, you're going to be preventing only 1 death from prostate cancer. So the false positivity, overdiagnosis, and risks associated with prostate biopsy are main concerns. Let's discuss this a little bit more. False positivity means that when you get a screening, which is usually the PSA test that I will be explaining a little bit more in a bit. So when you have an elevated PSA level, it could be due to reasons other than prostate cancer, very often. And so if you have an elevated PSA level, and if it doesn't get repeated and you're sent for biopsy, prostate biopsy directly, there's a good chance that that prostate biopsy is not going to show cancer. All the anxiety around it, for a cancer that you will never need any treatment for. So that's why overdiagnosis is a problem in prostate cancer screening. And prostate cancer screening can cause some complications, oftentimes arising from prostate biopsy. It could be an infection in the prostate. These are small risks, or it could be a bleeding in the prostate, but still not pleasant. So the recommendation for this reason is that discussion for prostate cancer screening should begin at age 50 for average risk man, and at age 40 to 45 for high risk man. And the screening should be a shared decision between the patient and the physician. So what is the method of screening? It's, as I mentioned, is the PSA test. PSA means prostate specific antigen. It's a type of protein that is made in the prostate tissue. It is secreted from healthy prostate gland as well. So there will always be a certain level of PSA in your blood, but in normal situations, that will often be undetectable or at very small amounts. When the prostate gland develop cancers, the PSA level will be much higher in the bloodstream. But there are many other conditions that will increase PSA level in the bloodstream too. These are urinary tract infections or prostate infections, vigorous exercise such as like biking for miles and miles, recent sex, or certain medications. So if you decide to get screened and if you have a PSA level that is elevated, then your physician should repeat it in 4 to 6 weeks to see that if the elevation is persistent, or look for other causes, whether you could have an infection or whether you have a recent sex, etc. If the repeat level is still elevated, then you can discuss the role of prostate biopsy in further exploring the possibility of cancer. The digital rectal exam has no longer role in screening. So this is a really nice figure to explain why the prostate cancer screening is debatable. I got this from the website of USPSTF, United States Preventive Services Task Force, and this really shows nicely why it's controversial. So let's say you screen 1,000 men with PSA for prostate cancer. About 240 men, so almost 25%, will have an elevated PSA level. It's very, very common. And this will not always be due to prostate cancer. There will be other reasons for PSA elevation, as I just mentioned. And some of these men will have a prostate biopsy done. Out of those who had a positive biopsy finding, only 80 of them, let's say 100 of 1,000 men had a positive prostate biopsy findings for prostate cancer. About 80 of them will undergo surgical removal of prostate gland or radiation to knock the prostate out. And these treatment modalities are associated with certain risks, such as erectile dysfunction or urinary incontinence. Some of these men who have positive prostate biopsy, meaning that they have a diagnosis of prostate cancer now, they will not need any treatment anytime in the near future. So out of 1,000 men who you screen for prostate cancer, you will only prevent 1 death from prostate cancer, and 5 will die from prostate cancer anyways. So the rate of mortality in prostate cancer is not so high, because it's a slow growing cancer. By the time the prostate cancer becomes a real problem, oftentimes the patients will die from other illnesses. So that's the prostate cancer screening. And now we're going to briefly discuss ovarian cancer screening. I'll be quick a little bit because we're getting into the last 15 minutes. Some facts about ovarian cancer. It's not a very common in average risk women. There are about 22,000 new cases of ovarian cancer every year in the United States, and there are about 14,000 deaths. Although it's not very common, it's a very mortal disease. The death rate from ovarian cancer is really high. Some women will have certain risk factors for ovarian cancer. Some of these are a personal history of breast cancer diagnosed at age younger than 41, personal history of breast cancer that is diagnosed over 50, but with some positive family history concerning Ford Lynch syndrome or Ashkenazi Jewish ancestry, or personal history of having a triple negative breast cancer, or the case that you have BRCA2 or 1 or 2 mutations. So if you have any of these risk factors, even in this setting, ovarian cancer screening is very debatable because we don't have great screening tools. But you might qualify for certain procedures to prevent from ovarian cancer if you have these risk factors. So it's important to know these factors and discuss with your physician if you have any of these, because ovarian cancer is a mortal disease. The mortality rate is high. Many patients will be diagnosed at advanced stages, and it's going to be incurable in that case. What are some symptoms of ovarian cancer? The most common symptoms are bloating or increase in the girth of your belly while losing weight, especially some pelvic or abdominal pain out of blue or after sex, abnormal bleeding, some back pain. So these could be some symptoms of ovarian cancer. There's really no existing method of screening with proven efficacy. There's a test called CA-125. It's a blood test, but as in the case of PSA, it can get elevated in a lot of different conditions. And there have been multiple studies looking into cancer screening and ovarian cancer, but these efforts have led to unnecessary procedures and false positive. So that's why ovarian cancer screening has no role in average risk women, because we don't have the methodology to do that. But high risk women should be referred for a genetics evaluation because they might qualify for prophylactic or preventative removal of ovaries if they have a certain amount of risk for development of ovarian cancer. So what are the conclusions? Start discussing cancer screening with your doctor. For colon cancer, start the discussion age over 45. For breast, age over 40. For lung, age over 50 if you're a current or past smoker. And for prostate, age over 50. These recommendations, screening recommendations, are subject to change very often. So it's really important to discuss this with your physician. If you have a strong personal or family history of cancers, then you should talk to your doctor about genetic counseling. Because if you have high risk for certain cancers, you can benefit from more extensive screening or certain surgical procedures to prevent the development of that particular cancer. And oftentimes, almost all private insurances will cover genetic counseling. Medicare and Medicaid will cover genetic counseling if you have a personal history of certain types of cancer. I'm not sure if you don't have a personal family history of cancer, if you only have family history of certain cancer, I'm not sure if Medicaid or Medicare will cover that. It is best to inquire about it by simply asking this question to your physician, and they can refer you to a genetic counselor and look before you make the appointment. They can check to see whether your insurance will cover this visit and the tests associated with it or not. So that's the end of my talk. I can take if there are any questions. We have about 10 minutes to discuss the questions.
So, Dr. Yilmaz, it was a great and informative presentation.
Thank you.
I really learned a lot. I was like listening all the information and the slides one by one. If there is no question, I'm still waiting we can simply finish our presentation. Oh, there's one person says, oh, thank you. Oh, so it's to you, Dr. Yilmaz.
Sure, thanks for listening. All right, I guess then we can wrap up if there are no questions.
So can I ask a question for
Sure.
myself? Okay, so our family doctor actually referred me to have a mammogram. And I was kind of like hesitating to have that. So how often I missed that the year frame. How often should we have it? Because I remember 5 years ago I had one. So
So it depends on your cancer risk. If you don't have a strong family of breast cancer, and if you don't have much risk factors for breast cancer, if you're an average risk individual, then there is not a very strong benefit of breast cancer screening prior to the age of 45. So I would start discussing it around age 40 to 45, but would consider to start after the age of 45. And you can get screened. Maybe what I would recommend is that maybe like twice a year screening until the age of 50, and then make it more often, at least between the age 50 and 60, like annual screening once a year. And then if no abnormal findings in that time period in any of your mammograms, then you can space it out to every 2 years.
Okay, because maybe because of my sister had breast cancer.
I see.
Most probably because of that, they want me to have one.
Yes, then that might put you in a higher risk category depending on the age that your sister got diagnosed with breast cancer. So you might need annual screening actually.
Okay, thank you. So these are actually very important information that we should know, because so many of these information that you mentioned that we don't know.
Yes.
And we are not aware of these factors really.
And actually the main point that I wanted to emphasize here is that majority of the cancer screening costs have to be covered with your insurance, even though you have Medicaid, because these are like government recommendations. The same institution or authority who provides you that Medicaid or Medicare insurance coverage. So you shouldn't be afraid of the costs that might arise from these visits, because it has to be covered. If it is not covered, then for example, the breast cancer screening is covered under the Affordable Care Act. If the insurance company is billing you, sending you a bill, then they might be breaching Affordable Care Act, which is a big deal. So just know about your rights, that this is free and available for you after a certain age. So, and get it done. It really is, in the case of colon, breast, and lung cancers, it is really helpful, and it prevents deaths from that. Prostate cancer, ovarian cancer, maybe not so much, but the other 3 types are very important.
I think there is a question that would you like to check, or do you want me to read it to you?
I can read it here. Is there any medical center that does screening for free? Again, that's what I was saying. It is free as long as you have any type of insurance. It could be Medicaid, it could be private, or it could be Medicare, and for some individuals, it is free. Because I believe these facts about screening should be reminded from time to time, because people tend to ignore or evade. Yes, that's so true, because there is this stigma around the diagnosis of cancer. A lot of people don't get screened because of the anxiety of having a cancer diagnosis. But again, the end result could be way more devastating than having a transitional anxiety of cancer diagnosis. The end result could be that you're now too late, that you have a cancer already and it's at advanced stage and it's no longer curable. So just like try to beat that anxiety and get screens, because it can save your life.
Yeah. So can we call it like we cannot run away from the truth?
Yeah, that's true.
Yeah.
Oops. All right. I guess you're just
okay. If you want to wrap up, we can.
I mean, if there are any more questions, I'm happy to answer. If there are no questions, I guess we can just end at this point.
And thank you very much for finishing on time, because sometimes we were like having overtime and issues. So thank you.
Sure. Thank you so much for listening and giving me this opportunity to talk about this very important topic that everyone can benefit from.
Yeah, we all appreciate it. Thank you so much for coming, and hope to see you again, because yeah, this one was our 7th health awareness program, sponsored by Whitetulip. So I'm hoping to have more, and thank you so much.